Right, we're going to review Module 7, so for MedSurg 2. So inflammation, immunity, and hypersensitivity, all those topics combined, all the different reasons that you have put together. So the concepts and interrelated concepts, there's probably more than this. These are what I pulled out from the readings. Immunity, inflammation, right? Infection, gas exchange, pain, and then perfusion. So some of the exemplars: anaphylaxis, transfusion reactions. We're going to review liver transplantation, kidney transplantation, that organ rejection, organ failure. Then anaphylaxis is associated with distributive shock. ICU delirium, which actually I pushed to further, so you won't have that in this section. And then infection. So you have two chapters that you're supposed to review, 16 and the infection chapter. So make sure you do review that information, reread it, because it's really the backbone to immunity. So, when we look at distributive shocks, so we know there's like 4 different types of shocks. So I've divided up all the shocks into what makes sense with the reading materials and the concepts and exemplars. So distributive shock actually has a whole laundry list of things that it can be associated with, but we're associating it with here with anaphylaxis. Anaphylaxis, sorry, I can't say it. So what distributive shock is, it's when the blood volume, it's not lost in the body. You have the same volume of blood, but it's distributed to your interstitial tissues. So your organs aren't getting perfused. So your total body volume is normal, or it could be increased. So the one in table 34, task 1, it'll show a whole list of different reasons for distributive shock, but the one we're focused on at this point is anaphylaxis. So the end result is you have the blood vessel dilation, right? Because you have pooling of blood in the venous and capillary beds, leading to increased capillary leak, so like edema, and you have a decreased mean arterial pressure. The decreased mean arterial pressure with the normal volume of blood. There's a picture in the book as well that shows 4 different types of shocks in that chapter, and showing whether it's normal volume, if it's leaking, anything else. So pulling the blood, distributive shock. So anaphylaxis is one cause of that distributive shock. But anaphylaxis is a type 1 hypersensitivity reaction. Now, we went over type 1, 2, 3, and 4 last semester. Type 1 is really the most common, right? But anaphylaxis is the most severe, life-threatening. It involves all blood vessels and smooth muscle. So it causes bronchoconstriction and vasodilation. You have those, like it says, widespread blood vessel dilation. You have a decreased cardiac output due to the vasodilation, and you have those bronchoconstrictions. It's the most life-threatening reaction. So failure to rescue, failure to recognize these cues, and delaying in your administration of epinephrine can lead to death. Teaching our patients. So the book goes into 3 different criteria, and you might say, well, really, what's the difference? So criteria 1 happens within minutes to hours. So it's as a end result of skin or mucous membranes, swollen lips, tongue, uvula, hives, pruritus, itching, a flushing, or any one of these acute symptoms below, which is your respiratory distress, your bronchospasms, wheezes, stridor, obviously a sign of an impending doom, impending respiratory failure, hypoxia, cyanosis, and dyspnea, shortness of breath. And then hypotension can be an indication of reduced perfusion. So looking at decreased perfusion. So criteria 1 is within minutes to hours. Criteria 2 over there on the right is within minutes to hours. You have 2 or more of these symptoms. Okay. Skin or mucous membranes, you can read through them. Respiratory distress and similar. They have some persistent GI problems, nausea, vomiting symptoms. Those are the first symptoms they might have: unexplained nausea and vomiting, abdominal cramping. Hypotension is also evidence of reduced perfusion. And then criteria 3, it's minutes to hours of hypotension with your systolic blood pressure is less than 90. So you might say, am I going to really look at this? Well, your patient outcome is what's most important, or preventing any of these from occurring, or identifying early those cues that these patients are going to have a untoward effect, poor outcome. So they start talking about pruritus when they're getting an IV antibiotic or getting blood transfusion hanging, or they have a new medication being administered that they've not had before in the past. Their lips start swelling, their tongue starts swelling, they have difficulty swallowing, they're drooling, they can't speak, you know. Like I said, the hives and itching, but stridor definitely. So, and we'll go over some of the things here next on what you want to worry about. So what do we have to do as a nurse? So you always assess your airway, breathing, circulation, and these aren't in order. So you need to think about what's going on with your patient as to which you would indicate first. Well, airway, breathing, circulation is always first, correct? If you don't have an airway, they're going to die, right? They're having stridor, and you need to make sure you have your respiratory emergency equipment there. But you know, call an RT. So you are going to want to have intubation and tracheotomy equipment ready with anaphylactic emergency. Oxygen with high flow, maybe in a non-rebreather. If they have an infusion going that's causing this, you want to discontinue it, stop the infusion right away. Right? But never discontinue that IV because you're definitely going to need it. You'll end up giving epinephrine intramuscularly. You can give it intravenously as well, and you can give Benadryl and steroids depending on what they need. So if you don't have an IV, you need to start one, but it's really going to be much more challenging because they're going to be vasodilated. So it's harder to place an IV when they're vasodilated. Prepare for that epinephrine IM. You can give it every 5 to 15 minutes, but you don't give it an injection of epinephrine and then send them on their way. You know, you have to reevaluate them because that antigen, that exposure that's in there could still be in there lingering, and the epinephrine might stop. You know, it'll stop working. Its efficacy works. Head of the bed about 10 degrees at least. Now, if they become hypotensive, I mean, if you can get it higher, yes, but head of bed at least 10 because it's just for aspiration precautions. But if they're hypotensive and you have their head up, you're gonna have to lower it. Raise their feet and legs, and always stay with the patient. So once again, these aren't in any specific order other than always ABCs are your priorities. But you know, lack of administration of epinephrine, the inability to administer the epinephrine increases the patient's risk for death. When we're talking about anaphylaxis, the one thing that I don't have in these slides is really what we're going to teach our patients. So, and that was more last semester, but just remember, make sure you educate your patients when they go home with an epinephrine pen. They always should carry 2 around, and they should be checking for what expiration date, looking for the color and the clarity, making sure they know how to utilize it, making sure they need to come to an ER after they might use epinephrine, and use it, vice don't use it. Better off administering it if they have any hesitancy or concern that they might be having a reaction to whatever allergen that they have been exposed to than to not. Okay. So leading into true infusion reactions. So acute transfusion reactions, and we'll go into the different types that you can have. And once again, you're going to say, well, is the treatment going to be any different? Potentially, but a lot of times not. So it's more common when the blood is older, greater than 30 days old, more at risk for bacteria. Multiple transfusions administered. The more transfusion a patient is exposed to, the more antibodies and that the patient has built up. So whether it's to the white blood cells that are within that donor's blood, to the plasma that's in there, any antibodies that might be in there. And then minimizing your risk for transfusion reactions, making sure you're following the nursing protocol during initiation, from the moment you draw the blood, the check and cross, to the minute it gets infused to the patient, whether it's picking up from the blood bank, typing 2 RNs verification at the bedside, transfusion per hospital protocol. You start slow and monitor the patient. So, every hospital might have a little bit different protocol, but you're going to stay with the patient for the first 15 minutes, right? You do vital signs every 5, typically 5 to 15 minutes. Right? And then educate them on signs and symptoms of transfusion reactions. So you must you need to understand what they are as well. Classics are back pain, with a fever, shortness of breath, itching. Those are the classic ones. You can have hematuria and other things too, but that's going to come a little bit later. And remember, blood transfusions can only be infused with which solution? Saline. You'll hear anesthesia providers and other people do different things, and it's incompatible. Excuse me, incompatible with any other medication, which makes no sense sometimes because you think, well, I'm going to push meds in my blood, but we don't want to put the patient at any greater risk for anything. So here are your types of transfusion reactions. You have febrile, hemolytic, allergic, bacterial, the TRAL, which is the transfusion-related acute lung injury, and then you have your TACO, which is transfusion-associated circulatory overload, and then your graft-versus-host disease. So febrile is probably one of the most common ones. It's really common after patients that have received white blood cell transfusions, platelet transfusions, or multiple transfusions for what I said earlier. They have anti-WBC antibodies. So what is the donor blood that's being, or the donor white blood cells or platelets that are being transfused, the patient has built up antibodies to it, especially for patients who've received multiple transfusions. Most of the signs and symptoms on all these transfusion reactions are very similar. Chills, tachycardia, fever, hypotension, and shortness of breath. You can minimize a febrile transfusion reaction, especially in a patient who has a known, let's say you have a sickle cell patient or an oncology patient who receives transfusions frequently throughout their lifetime, throughout their treatment protocol and regimen. So you can use a leukocyte-reduced filter. I mean, you can use leukocyte-reduced blood, which means the white blood cells have been removed from the blood, okay? Or a single donor HLA match. So that means they have matched a donor's HLA with the donor versus the recipient's HLA's match. Or you can use a WBC filter, which sort of filters out the white blood cells, decreases that risk for having that anti-WBC antibody attack. Hemolytic, what does hemolytic mean? Destruction, right? Hemolysis. It's a blood type or Rh incompatibility. So we've had an error along the way somewhere, right? Blood has antigens, right? I might have to stop this because the dog's going to start barking. With hemolytic, it's the antigens from the donor blood versus the recipient's blood are different, right? So the patient is going to be destroy the transfused cells, and it will immediately start that inflammatory response or process. It can be mild or life-threatening, or they can end up with disseminated intravascular coagulopathy or coagulation. Immediate, or it can happen after subsequent units have been transfused. So you have febrile and hemolytic. Allergic, we think of anaphylaxis. Patients with other allergies are at greater risk for having an allergic transfusion reaction. So that itching, the urticaria, bronchospasms, and those classic anaphylactic symptoms. A lot of times you'll pre-medicate patients with Benadryl, right? Sometimes they get a H2 blocker as well, but definitely they'll be pre-medicated with Benadryl, and they'll have taken it the day before as well to help build it up in their system to decrease the histamine release. You can occur during or up to 24 hours afterwards. Once again, they can administer leukocyte-reduced or washed red blood cells. Those washed red blood cells take out the white blood cells and the plasma and that IgA. So it's all been removed. Bacterial contaminated blood. Specifically, and even worse, is with that gram-negative organisms. It was almost an immediate reaction. So tachycardia, hypotension, fever, chills, and shock is very rapid. I think I told you guys before with patients who've had triple lumen catheters or central lines, and this is sort of off the topic, but when you think of that gram-negative organism and how fast the reaction happens when you start to infuse. I've flushed central lines that have had a biofilm of bacteria on it, and as soon as I flush it and one of the little emboli comes off the tip of the catheter and floats around, the patient will start rigering, become febrile right away, and then it'll resolve. So acute lung injuries, when they've had antibodies against the recipient's neutrophil antigens, or that HLA. So acute lung injury, the donor blood contains antibodies against the recipient's neutrophil antigens, or HLA. So rapid onset, they have shortness of breath. You have to early identify these patients and any dyspnea that they might have. They often require intubation and mechanical ventilation, or it leads to death. With circulatory overload, happens probably talked about it in ACCC. In the older adults, greater at risk, right? We infuse the blood too fast. So we do have protocol. If you're on the med-surg floor versus the intensive care unit versus the trauma bay, you're going to transfuse blood differently, but it's dependent upon what's going on with the patient as well. So just because you're giving somebody blood down in the ER doesn't mean you bolus it. Now, if they are bleeding out or they have a traumatic injury and they need blood, you will rapidly infuse it. So the older adult is much more at risk of having a circulatory overload. Right? It can be difficult to differentiate the two because they're both going to have some shortness of breath. Right? It's going to present with the same signs and symptoms, but it's often with whole blood, so there's more components. There's the TACO circulatory overload transfusion associated is treated with diuretics and monitor I's and O's and slowing the rate down. So if you catch it, so trying, that's why we assess our patients frequently. Let's figure out. And transfusion-associated graft versus host disease. Most of the time, this is rare, and you're going to see it mostly in those immunocompromised patients. So if you read on transplant patients, like stem cell transplant patients with leukemia, that's where you're going to see this happen more often. So the ones you're going to see that are most common are febrile hemolytic, then allergic, and bacterial, hopefully you don't see often. And the other two as well. Hopefully you see none of them in practice. But you will see a transfusion reaction at some point. So what do you do? Once again, just like everything else, you stop the blood, stop the transfusion, notify the physician immediately. There's an entire form that you have to complete and fill out. You'll remove the blood product and the transfusion tubing and save it. You'll put it in a bag. You'll fill out a form. You'll draw labs from the patient. You're going to give normal saline infusion with the new IV tubing, especially if they appear hypotensive, like poor perfusion, like they're vasodilating out. So, but new tubing, you never flush through the rest of that line, even though you have saline hanging in that bag. Otherwise, you're just going to prime it with another 15 to 30 milliliters of blood. Monitor your patient, monitor urine output, right? You want to make sure that you don't have any hemolytic problems going on. Record their vital signs until stable. And they recommend hourly urine output to make sure the kidneys are still receiving perfusion. There's no acute kidney injury. There's no blood in the urine, hematuria. Always recheck the tags, make sure it's right patient, right blood. Notify the blood bank, and then fill out that transfusion reaction report. Okay. You'll end up giving the patient, it really depends on what the scenario is and how quickly you caught it. Did they start complaining of back pain and fever, or back pain and chills? Stop the transfusion. And sometimes, depending on what the patient needs, if they need that blood and you have the time to identify and look, you'll treat them with IV Benadryl and do a really slow infusion, as long as you can get it infused within the 4 hours from the time it left the lab. Anything longer than that, your patient's at risk for having the back blood getting infected. Let's go on when we talk about liver transplants. So we talk about liver transplants and kidney transplants. The book doesn't have as much about liver transplants as it does on kidney transplants, but just remember that both of them have some contraindications to the patient receiving that transplant. So for patients, liver transplantation is for patients with end-stage liver disease or some acute liver failure, right? There are transplantation considerations and complications, which we'll go over a little bit of it. You have to be able to teach the patient about the complications of it and what is considered when the patient's put it on the transplant list. So, and then our interventions after transplant that we have to look at with patients is our psychosocial impact. the side effects of immunosuppressive therapy drugs because they're on them for long term. Can they manage it? What put them in this transplant need list? So, did they have chronic hepatitis? Did they have cirrhosis? Were they, if you, last semester on the transplant ward, and I was doing clinicals with the students in traditional, it was a kidney liver transplant floor, and it was really interesting. They've seen a spike in liver transplant needs in patients with cirrhosis due to COVID, due to increased amount of alcoholism and intake of EPOH. So patients that are contraindicated, not a donor recipient, not be able to receive a donor, are exposed with cardiovascular instability or really advanced cardiovascular disease. They have a severe respiratory disease. They have metastatic cancer, metastatic tumors, and they won't follow the drug therapy. They're unable to follow instructions. So it's useful to give them a kidney if they're not going to follow through with the immunosuppressive therapy for the remainder of their life. Donors. So liver transplant donors, they can be either from trauma victims that have no liver damage. And with this, we're assuming that they are a known, they have it on their ID card, or their family's there, and they're a known organ donor. So patients with the highest acuity level receive highest priority for receiving that liver. Okay, highest acuity versus lowest acuity is the more critically ill. Okay, the liver is transported in a preservative that lasts for about 8 hours. So the diseased liver and the recipient is removed. Okay, and they put the new liver in its place, and they test the blood vessels and the bile ducts to that. Sounds simple, huh? But it's it's done frequently. With a living donor, it's usually you have a family member, close friend, or a spouse, and it's a voluntary basis. You must be at least 18 years old, and they have to have testing complete, make sure their LFTs and everything else are within normal range. The donor liver is resected. Typically, they'll take one lobe, and that's what's implanted into the recipient after they remove that diseased liver as well. So both livers actually regenerate and they grow, and to meet the specific body's needs. The complications, so with both kidney and liver transplant, your complications are going to be graft rejections, right? So acute graft rejections are treated really aggressively by taking immunosuppressive drugs, increasing that dosing of those immunosuppressive drugs. That can lead to multi-system organ failure and also coagulopathies and portal system encephalopathy. So they can have confusion and everything from the liver not clearing and cleansing. With infection, we try and prevent the infection by the administration of vaccines, and this is where you're actually going to see prophylactic antibiotics pre-surgery and during surgery. Okay, immunosuppressive drugs do what? They increase the patient's risk for infection because they're suppressing the immune system. They're suppressing the immune system so your body doesn't fight off the foreign body placed in there, the donor's liver that's in there. Okay? So they are on immunosuppressive therapy. And they're at risk for infection just from the multiple tubes and intravascular lines that are placed in them. They're going to have catheters placed, they're going to have central lines placed for monitoring volume status, for transfusion of blood or fluid. They're at risk for bleeding, disseminating coagulopathy, or risk for bleeding from the site of anastomosis. They can have hepatic complications. They can have bile leakage. They can have an abscess that forms around the transplant site, and they can have thrombosis, hepatic thrombosis, clots that form and occlude off. So if they have hepatic thrombosis, a lot of times they'll go in there. They can, if it's depending on how long it's been since the surgery was placed, and they can do like a PTCA in there. And then they're at risk for acute kidney injury from what? Hypoperfusion. And surgery. The hypothermia during surgery puts them at greater risk. The cyclosporines do, the nephrotoxic medications, and the antibiotics. So kidney transplantation. Section was a little bit more of reading. the criteria for selection for candidates criteria is advanced kidney disease, right? Reason, and what's your life expectancy? What's a reasonable life expectancy? Well, they will have a checklist that tells you, but you're not going to give it to the 88-year-old person that's walking around by 23-year-old. Sounds horrible, but still, they have to be medically and surgically fit for the procedure. They have to be able to understand, go through anesthesia, be under, anesthesia for a long time, up 3-4 hours. And they must be in the U.S. On the wait list, and they are put on the wait list when the glomerular filtration rate becomes less than 20 milliliters a minute. So, candidate selection criteria. So the contraindications, once again, active cancer, they're worded a little bit different, but current infection, with hepatitis, you often have an ongoing infection. You can, whether it's viral or bacterial. So with kidney transplantation, you can't have a current infection. You can have psych issues. Substance abuse. And honestly, with liver transplant, the same thing. They cannot be drinking alcohol still. So, and a patient who's contraindicated for kidney transplant is one of those who's been non-adherent with dialysis or the medical regimen that they've been prescribed, because they're not going to be compliant with the immunosuppressive therapy that they have to be on, or the potential dialysis they might be on, even post-kidney transplant. There's living donors, there's non-heart beating donors, and then there's cadaver donors. So the living donor obviously has the best survival rate, right? They have less time of that kidney being cold, so shorter cold ischemia times. And they have less ischemia reperfusion injury because the kidney hasn't been hypoxic for very long. So that donor must be over 18 years old. What's interesting about kidney donors is they must type and cross, they must match, they must have the same blood type, all right? Whereas in the liver, they don't. So often it's a family member that's willing to give up one of their kidneys. So non-heart beating donors is typically harvested immediately post like cardiopulmonary resuscitation where somebody has died. And you're assuming that the patient has already signed, or it's on their, like I said before, their driver's license, that they are a organ donor. Otherwise, they have to preserve it by infusing a cool preservative solution into aorta to cycle through the kidney until they can get approval. And then cadaveric donors are the least likely to be successful. Obviously, the patient has been dead for a long period of time. So pre-op and post-op and operative. So similar to, liver damage a liver transplant, you're going to have pre-op requirements. Photo on the next slide. And it's from the book. So it's right here, right? Why do you think it's placed there? Easier to attach to the urethra and the artery and veins, okay? And it's easier to palpate than it is when your kidneys are up here, in the posterior portion of your back, lower spine area. So they are going to have urological management. They're going to follow a nephrologist. Post-op, you're going to assess urine output hourly for 48 hours. Okay. They might need continuous bladder irrigation, especially if they're having clots formed to keep the kidneys perfused, the bladder perfused, that is. Monitor eyes and nose, and daily weights, looking for fluid volume, retention, right? Kidneys not making urine. Routine catheter care, because they are at risk for a cavity, right? They normally keep them in for, I think the book says like 3 to 5 days. They want to get them out as early as possible, but they need to be able to monitor urine output. So monitoring for that fluid overload, that's also done dually by taking your daily weights, and then checking the blood pressure every 2 to 4 hours. So immunosuppressive therapy reduces the patient's immunity. It impairs healing, and it increases their infection risk. So why do they take it? Well, we have to keep them from attacking the donor kidney. So, but these patients are always at risk for infection, for wound healing, and risk for nosocomial infections. Okay, oliguria is also something we're observing for or looking for. It can be caused from ischemia or acute kidney injury or rejection. It's treated often with diuretics and osmotic agents. So something that's going to whole water. Remember, albumin, good osmotic agent. And then diuresis. They can have, so oliguria is more common in a non-heart beating donor, whereas diuresis is more common from a living related donor because that kidney has reperfusion with her, correct? So you want to monitor them for low potassium and sodium levels because of that diuresis and monitor them for hypotension. Complications, okay? You can reject it. You can have a hyperacute rejection, acute rejection, the chronic, and renal artery stenosis, and then just the others. So you can read through this all, but rejection of the kidney is very similar to the rejection of the liver. It ultimately leads to destruction, thrombosis, and necrosis if it is not caught early. Why we're monitoring vital signs, monitoring urine output, monitoring weight, looking to see, monitoring hourly output. Okay. Hyperacute, within 48 hours, they'll be febrile, maybe not febrile, but increased temperature, blood pressure, and pain, kidney pain. They remove the kidney. Acute rejections is 1 week to any time after. So oliguria and urea, they have lethargy, that kidney is tender and enlarged. What else? Potassium and fluid retention. So they increase the immunosuppressive therapy. So where they might be on a high dose already, they're going to push it even higher to try and keep that rejection from occurring. Might end up doing a kidney biopsy to see what's going on as well. Chronic, months to years. It's just a gradual increase in that BUN and creatinine. They start having fluid retention. They're tired as well because they aren't able to clear everything out of their body and their kidneys and their erythropoietin and everything else. So they'll have serum and electrolyte changes. We treat with conservative management as long as possible, and then dialysis and stenosis of that renal artery. That renal artery, if it becomes stenosed, can result in what? Hypertension, as we know. You can hear a bruit over that anastomosis site. They have decreased kidney function, and obviously evaluations with CT. And similar to any other narrowing or stenosis, they can treat with balloon angioplasty. It just really depends on how close it is to the surgery to make sure they do not, rupture sutures. And then infection, hematomas, abscess, and lymphocytes, right? So we prevent this by strict aseptic techniques and hand washing. These are, they're put on corticosteroids and inhibitors of T cell proliferation and activity. So the atropine and cyclosporine. Cyclosporine is the one you're going to see the most in corticosteroids. I see cyclosporines all the time. mTOR inhibitors, mononuclear antibodies. They start with that high dose induction followed by a lower maintenance dose. Our goals with patients with kidney transplants is similar to liver transplant, avoiding infections, using effective coping strategies, just, it's a change of lifestyle. So maintaining electorate, that's appropriate fluid and electrolyte balance, and nutrition. Oh, it's a duplicate. All right, here's a question for you. So I think you guys can probably guess this one. Registered nurse caring for a patient who received a kidney transplant. When the patient says, "What will I do? Transplant doesn't work." What's the most appropriate response? C, right? You don't want to belittle them. They're not always successful. There's not always a guaranteed another donor, right? Talk to them about it.